Good morning, and thank you everyone for joining us in this first international conference organized by the French Collaborative Institute on Migration for this session, where we will specifically discuss issues regarding migration, racism and discrimination in health. The title of our session is Racism and Health When the Healthcare System Discriminates, and this session has been organized by the Department of Health of the National Collaborative Institute of Migration. So it's my great pleasure to chair this session. I'm Maria Melchior. I'm an epidemiologist, and I'm in charge of the health department in the institute. It's my great pleasure to welcome the 4 speakers who have agreed to be part of this session, and who are James Nazroo, Mathieu Ichou, Priscille Sauvrin, and Francesca Cerna. Very broadly, we will talk about racism in health and the role of the healthcare sector, the role of different aspects of discrimination towards patients as well as towards healthcare workers who are foreign in different healthcare systems. And each speaker will present data and some thoughts on this topic for about 20 minutes. And we will have a 25-minute question and answer session at the very end. So please, if you have any questions, write them in the chat, and I will then forward them to our speakers at the end of the session so that we can have a general discussion. So our first speaker is Professor James Nazroo, who's a medical doctor as well as a sociologist and professor of sociology at the University of Manchester. Hi, James.
Thank you.
He's conducted for many years very novel and groundbreaking research on ethnic inequalities with regards to health, and also with regards to access to the healthcare system, specifically working on different aspects of migrant and ethnic minority groups' identities, and the way in which different forms of disadvantage can accumulate over the life course to produce ethnic inequalities, which we're all well aware of, especially in the context of the COVID-19 epidemic, which has brought these inequalities to the front line. Lately, he's been working on issues specifically related to ethnic inequalities with regards to aging, and we're very excited to have him here with us today. And the floor is yours, James.
Thank you very much, Maria. I really appreciate the opportunity to be here and to talk about some of my work. So the focus of my talk is on inequalities in health. So it's not so, although I talk about the healthcare system, it's on inequalities in health more broadly. Inequalities in the health of ethnic minority people within the context of the developed world. So the post-migration context, and of course, what partly shapes that post-migration context is history and the historical forces that have driven migration. My core argument is that we cannot get an adequate understanding of these inequalities unless we move beyond common sense approaches to understanding ethnicity. Common sense, data-driven approaches, and think more theoretically about what might be driving these ethnic inequalities, the resulting processes that flow from what might be driving this, and then think about the ways in which those processes might be intervened on. So we need to think about interventions that can disrupt causal processes, but we cannot identify those causal processes unless we think more theoretically, rather than from the common sense understanding of what ethnicity is. And central to that, of course, as you will see from my title, is the question of racism and discrimination. This is what drives my focus on racism. But it's more than just naming racism. It's about trying to understand how racism operates in our societies, how racism then shapes the lives of ethnic minority people, and then what that means for their health outcomes. Before I go on, I'll just say a couple of things about the logos on my slide. So I work at the Centre on Dynamics of Ethnicity at the University of Manchester. It actually crosses a number of universities within the UK. And that's the logo at the top. At the bottom, you'll see the Evans logo, which is a big survey that we're doing at this very moment to try and understand the impacts of the coronavirus pandemic on ethnic minority people. And then on the right, you can see logos of my employer, the University of Manchester, but also importantly, the Economic and Social Research Council, who have been funding a large proportion of my work in this field for the past 25 years or so. I'm going to first set context, talk about the UK and inequalities within the UK. I'll then talk about ethnicity and racism and how racism then shapes inequalities, and then try and have a final reflection on what that means for our thinking in this field and for interventions in this field. So start off by the UK context. So the UK has now for 30 years been collecting data at the census on ethnicity. The questions that we use to measure ethnicity have varied over that period, but on the left-hand side of this chart, you can see the questions that we used at the 2021 census. We don't have data from that yet, but on the right-hand side, you can see from the 2011 census how that distributed across particular groups. You can see each of these groups make up a very small proportion of the population. You can also see that the way we ask these questions relate to both race, ethnicity, and national origin. So all three of those concepts are wrapped up. And in essence, what the categories we have here are the categories that people use in their everyday lives. And so they are common sense categories and enable then us to pursue common sense approaches to explanation rather than thinking through what may lie behind these categories. And just to show you the extent of inequality in health in the UK in relation to ethnicity, this is a slide showing mortality rates in a relatively early period. That should say June 2020, not December 2020, a relatively early period of the pandemic. The publication was December, the period was June 2020. And what you can see is that for each of the ethnic groups included here, both for men and women, there's a large increase in the hazard of mortality. So the hazard of mortality is relative to the white hazard, which is 1, and the hazard ratio is much higher. These are incredibly high rates. So back in the 1990s, when I began my work in this field, a hazard ratio of something like 1.3 was a major cause for concern and led to a huge number of investigations. Here we're looking at hazard ratios that for many groups are above 2 and for some groups are above 3 times the hazard of mortality, age-adjusted hazards. So these are big differences. And this slide shows self-reported health by age group in 10-year periods up to 80 to 89, cross-sectional using census data. For a number of ethnic groups, the black line is the white British group, the yellow line with the highest rate is the Bangladeshi group, then the green line Pakistani, the red line Caribbean, and the blue line Indian, and so on. And if you look at the relative heights of those lines, you can then see within particular age categories from midlife onwards, from age 40 onwards, the rate of poor health is much higher for many of the ethnic minority groups. And if you look at the right-hand side at the 80 to 89-year-old, after a significant period of mortality, you can see the size of that difference. If you look at the orange line drawn across the slide, that's the rate of poor health for 80 to 89-year-olds, white people. And if you just look where that line, at the age point at which that line crosses other groups, you can see the very marked inequalities that are present there. So this is stark inequalities. And of course, if you have an age-related condition like COVID-19, then you inevitably end up back with these higher mortality rates. So how do we set about trying to explain these differences in mortality? And here I have a set of the kind of almost common sense explanations that we use to understand ethnic inequalities in health. First is they live in poorer ethnic minority people live in poorer circumstances. And those poorer circumstances drive inequalities in health. And we know this from the big literature on socioeconomic inequalities, of course. And these are deep and enduring. And then partly because of those inequalities, ethnic minority people are also more likely to be exposed to hazardous conditions. And I give the example for COVID-19, but you can imagine other examples, of course, for other conditions. And then they have a whole set of underlying chronic illnesses that put them at greater risk when something like a pandemic happens or when some other condition occurs. So diabetes, hypertension, cardiovascular disease, experience multi-morbidity, and then consequent vulnerability to future illness and mortality. And you can think about this in a number of ways. So the way that someone like me would typically approach this would be to say, these high rates of chronic illness actually reflect the first point on this bullet, on this slide, socioeconomic inequalities. But you can also imagine a line of thinking that these are diseases that are biologically driven, and there's biological vulnerability that has genetic underpinnings to it. And this is a very common tradition in the epidemiology of ethnic differences or race differences in health. And it has played out in COVID-19 in relation to these chronic conditions, arguing why diabetes might be more prevalent in minority groups, but also in relation to things like vitamin D in an unevidenced way. So these are explanations that are drawn upon in an unevidenced way. And then cultural vulnerability, ways of living that expose increased health hazard. And that might be wrong diets, might be wrong other health behaviors, might be living in multi-generational households, and so on. My argument, as you will see from the final 2 bullet points, is that we need to think differently about possible explanations. We need to think about racism, how racism operates, and that means we need to think about the processes that lead to the racialization of ethnic minority people, and how these processes shape life chances, what might be called fundamental causes in my language. So we need to think about ethnicity as a consequence of racism. So thinking differently about ethnicity, and here I have quotes from 3 or 4 sociologists, 3 quotes from 4 sociologists. And Steve Fenton argues, of course, that ethnicity is something symbolic in our lives. The languages we use, the behaviors we have, the religions we follow, and so on. But also there are material implications. So the way we think about ethnicity is not just about that, but it's also about where we live, the kind of conditions we live in, and so on. So both material and symbolic dimensions to racism. And John Solomos argues that these are basically takes a constructivist approach. These are discursive formations calling into being a language that we use to understand ethnicity and particular ethnic groups. But those understandings carry with them consequences for people who are named within an ethnic group, because they have meaning for those people. And then Mbea and Desmond make the very strong argument that the ways in which we understand these identities relies on a whole set of resources that we have available to us: economic, cultural, legal, political, and symbolic. That's how those are the resources that are drawn upon when we define what the symbolic meaning of ethnic categories are. And importantly, there are crucial symbolic resources that are used to mobilize this. Emotion, risk, danger, fear, and disgust are attached to ethnic categories, which then shape the practices of individuals and institutions who then interact with those particular ethnic categories. So racial life is suffused with shared passions, imaginaries, and fantasies, as well as that embody and reflect the markers of distinction that we impose between groups of people. Importantly here, of course, is that these processes of racialization don't happen uniformly across groups. So the way we imagine a Muslim woman compared with a man from Africa is, of course, different, but both are deeply racialized in these ways. So what does that mean in terms of racism? In terms of racism, there's been a large body of work, including work that I've done, that says socioeconomic determinants are crucial in driving health inequalities, driving individual risk of poor health. So things like lower incomes, lower status occupations, unemployment, how long you're unemployed, etc., exposure to environmental hazards, social inflicted trauma, the experience of racism itself, or other things that happen to us in our lives and the unequal distribution of those, and targeted promotion of unhealthy consumption. But what this does is individualize risk, and what we need to do is think carefully and thoroughly about the distribution of these risks across ethnic groups. It needs us, which then needs us to pay attention to the way in which these risks and institutional responses to these risks are shaped by processes related to racism. I'll give a brief definition of racism here, which is one that I'm sure you'll be familiar with. I won't go through it in detail, but remember that this does have historic grounding to it. And the consequence of it is that we generate a racialized social order where groups are valued differently within our society and consequently treated differently within our society. And my argument is that if we are going to explain inequality and intervene in relation to inequality, then we need to understand this racialized social order, the processes that lead to it, and then think about how policy and practice might be shaped in relation to these inequalities. I want to go into just a little bit of detail in relation to this by talking about understanding how racism shapes people's lives and subsequent inequality. And here I talk about structural racism, interpersonal racism, and institutional racism, and I'll talk about them in turn and show you some data in relation to that. So structural racism, I argue, is a reflection of inequalities in access to crucial resources, economic, physical, and social resources. And inequalities in these in the UK and elsewhere have persisted with little change across generations and periods. And this isn't just material inequality, but it also has cultural and ideological dimensions. We have to be able to justify why these inequalities are persistent, and part of that is an ideological denigration of the groups who face those inequalities. We know why Muslim people are poor because of who they are, rather than because of the context within which they live and how they've been racialized. And this involves state action as well as broader economic forces. And the resulting level of disadvantage and how it accumulates across a life course then makes a substantial contribution to ethnic inequalities in health. These are slightly old data, but they give you a sense of economic differences across different ethnic groups in the UK. Each one should be a third, and you can see that's roughly the same for white English people. But if you look to the right, you see increasing inequality with increasing proportions of the population in the bottom third of incomes, to a fairly extreme level for the Pakistani and Bangladeshi groups, where only 5 and just over 10% of them are in the richest third of income. And the consequence of that for health is obvious. The poorer you are, the poorer your health. And so the purple bars are the poorest third of incomes, and you can see higher levels of health, poor health for those groups. Crucial here, of course, is that rich people, regardless of their ethnicity, have better health. The richer you are, the better your health. And you can see that in each of the ethnic groups as well. And that when you make adjustments for these kind of socioeconomic inequalities, you begin to explain health differences. Interpersonal racism. This ranges from the everyday slights being ignored, being served later, people crossing the road and so on, through discrimination to active aggression. This is a form of violence that we experience, a form of violence that emphasizes the devalued and fundamentally insecure status of ethnic minority people, of those targeted. And it's not just those targeted, of course, it's people like them who also know this is happening and consequently have their identities undermined in such a way. It generates meaningful psychosocial stress, which impacts on health. And again, the evidence in the UK suggests that there's been little change in the prevalence of racism and prejudicial attitudes over the past 3 decades. Little change in levels, some change in some variation across groups, which I just want to briefly show you. So the blue line here represents levels of prejudice. It goes from 1983 to 2013, and you can see it sits comfortably between the 30% and 40% of the general population saying they're prejudiced against minority groups. No meaningful change over that period. And if you chart the politics over that period, which I won't now, but if you chart the politics over that period, you would imagine there would be big changes in that. The orange line shows an increase in fear of racism amongst Pakistani people who are Muslim. The purple line shows an increase between 2001 and 2008-9 in levels of experienced racism amongst Pakistani people. The green line and red line show fear of racism and experience of racism has not changed much for Black Caribbean people. The grey line shows a decrease in experience of racism for Irish people. I come back to my earlier point, which is that the way that groups are racialized varies. The meaning attached to those groups varies, but it also varies over time. And what we see is a rise in experience of racism for Pakistani people, reflecting anti-Islamic hostility post-terrorist events, in fact, preceding those terrorist events, but becoming amplified afterwards. And Irishness, of course, the meaning of Irishness within the UK context changed as the troubles in Northern Ireland settled. And racism impacts on our health. So here I have 3 measures of racism: the experience of racial harassment in the blue bars, the perception that employers discriminate against people like you in the green bars, and being fearful of racism in the orange bars. And for each of these, there is an accumulative impact on your health. And we've done much research exploring that, as have others, showing causal processes in operation. Institutional racism is the 3rd dimension that I want to talk about. And of course, this has a history originating in discussion in the United States, reflected in the routine processes and practices within institutions that translate into actions that negatively shape the experiences of racialized people, both routinized actions and conscious actions. And I'll give you a discussion of that in relation to the health service within the UK. And perhaps not surprisingly within an NHS context, in terms of the first point of access, which is primary care, general practice services, GP services, there are no inequalities in access. Ethnic minority people make, even after you adjust for health, ethnic minority people make as much use of primary care services as white people. And for those conditions that the GP looks after, there are largely no differences in outcomes. And so I've studied quite closely hypertension, raised cholesterol and diabetes, and shown no differences in outcomes. And we have hypothesized that this is because of the nature of that healthcare system. A healthcare system with universal access at the point of entry and with standardized treatment protocols. But when you start having to pay, and dental services is an example, you see marked inequalities in access. And you also see that institutional racism is evident in other areas of the UK NHS. So once you get through the gatekeeper, inequalities begin to emerge. Inequalities in access to hospital services, lower levels of satisfaction with primary care services and lower resourcing for the primary care services in the localities where ethnic minority people live, very high rates of maternal death, unbelievably high rates of maternal death for ethnic minority people, mismanagement of hemoglobinopathies. These are just some examples. And mental illness and psychiatric services. I just want to dwell a little bit, but only for a second or two, on mental illness and psychiatric services. We did some research with people experiencing severe mental illness, ethnic minority people experiencing severe mental illness. We asked them to take some photos just to summarize their lives. And this is the first photo that one of them showed us. So a person with severe mental illness who is consulted with by the mental health services in his locality on how they might improve what they're doing. And he says, to anybody else, these pictures may seem like a day in the life, but to me, they represent something a lot deeper. The picture with the wonderful sunset in the boardroom, in the buildings where I speak about my experiences of being a service user and how things can change. I then leave the building. I come down, I get in my car and I'm stopped by the police as my car has a log on the system stating I'm a forensic mental health patient. His experience of severe mental illness that's drawn upon by the NHS to improve their services, but shapes his everyday encounters with a whole range of institutions, not just the NHS, of course, a whole range of institutions that shape our lives. So, my concluding slide, and here are the headlines, I guess, from the talk that I've given you. My first observation is that racism is a fundamental drivers of the observed race, ethnic inequalities and risk of illness and mortality that we observe in our societies in the developed world, in the global north. In investigating this, it's important to examine the ways in which racism operates. And to do this, I argue that we should look at structural racism, shaping access to resources, interpersonal racism, creating insecure lives, and institutional racism, the hostility within which we are received by the institutions that should be supporting our lives. How they operate and how they operate jointly, how they are mutually constituted, how they penetrate each other's forms of action. So structural racism and structural conditions of socioeconomic disadvantage and interpersonal experiences of racism both create an increased risk of poor health, of illness, of mortality through the processes that I briefly outlined. But they also penetrate institutions. They shape our encounters with institutions, the meanings attached to ethnicity and race, the poverty, the poorer access to resources that people have and bring into institutions, and the ways in which they are then encountered and treated by the institutions. And these lead to unequal outcomes and go from education through employment, housing, criminal justice, politics, and more, as well as health and social care. And these institutional settings, what I describe as a meso level, represent sites where we see the concentration and mediation of both the structural forms of disadvantage and interpersonal racism. And within this, it's often described as the practices and policies of institutions, but it also involves the overt agency of individuals operating within institutions. And my final point is that if we focus on institutional settings, this may be the place where we can achieve the greatest change. If we can shape the experience, or if we can reshape the experience of ethnic minority people within institutions into more positive journeys through these institutions, and you've seen the list: education, employment, housing, criminal justice, and health, then we can potentially make a big impact on the ways in which other forms of racism penetrate their lives and shape their lives. However, we do need to remember that institutions operate differently and have different functions in our society. So we need to think about the ways in which different institutions may be enhancing racism and the impacts of racism in different ways, and may need to have institutional racism within them addressed in different ways. And I'll give you two examples here, but you can think of many. So the ways in which health services provide screening involves a different play out of institutional racism to the ways in which mental health services operate. Okay, a bit of a rush through, but thank you very much for listening and welcome any questions at the end of the session.
Thank you very much, James, for this very powerful and inspiring presentation. And thank you for ending on a positive note of things that can probably be aims for interventions that try to decrease the impact of racism on people's lives. So we'll take questions at the very end of the session, but please, if you have any, start sending them through the chat right away.